Morning. Listen, what we need to talk about right now is men's and women's health. And what we'll do is talk about women's health first, and then we'll launch directly into men's health, and then we'll take a break right about 20 minutes to 1. All right, so give me about 70 minutes and we'll be okay on time. Here's what we need to talk about in the realm of women's health. I need to make sure that you know about dysmenorrhea because it's so darn common. I need to make sure that you know about amenorrhea and when you make that diagnosis. I need to make sure that you know about one of the most common chronic women's health problems that we see. Obviously, that is PCOS. I have to make sure that you know about the latest cervical screening guidelines simply because they've been in use long enough now to be fair game on your exam. But the other reason you need to know about them is because they are heavily evidence-based, which means you ought to be using this in your clinical practice. We'll talk about vulvovaginitis. We'll talk about postmenopausal bleeding because I'm pretty darn sure you'll see a question on the exam about it. And in practice, you need to know what to do when that occurs. And then the last two things we'll talk about in women's health are really men's problems too. Osteoporosis and a breast mass or breast cancer. It's just that we typically see these and they're associated with more women than men. So that's where we're headed. When we're done here, we'll launch directly into men's health and do that, and then we'll call it morning. So hang with me. I promise you're going to make it. Let's start out with a question. What differentiates pelvic pain from abdominal pain? Like the same thing you'd use if you had to order a pelvic CT or an abdominal CT. What are you looking for? What is your marker? It is always pain below the umbilicus is pelvic pain. So in this perspective, I want you to think about it that way. Number one, look at this second question. Primary amenorrhea may be diagnosed by age 15 years. That means a woman who's never had menses or an adolescent. What should be present for this diagnosis? And it says select all that apply, which makes it a more difficult question. So listen, what might be present? I tell you, normal growth ought to be present, right? And the next thing is presence of secondary sexual characteristics should be present, but she still hasn't had menses. So I would circle number 1 and number 2, and let's talk for a minute about primary amenorrhea, because this is something we see in adolescence. So take a look. An absence of menses by age 15 years ought to really trigger you to consider this as a diagnosis. Now, you don't have to wait until age 15 to consider it. You could consider it earlier if there was an absence of secondary sexual characteristics. If there was abnormal growth, there was something else that triggered you to consider that something might not or something might be amiss. Very often when a patient has primary amenorrhea, there is an issue with that hypothalamic pituitary ovarian axis. There are many, many causes for this, and you might be able to make the diagnosis, but almost always you will have to refer for treatment. And who do you refer to? Maybe reproductive endo, right? So you'll have to see what resources are available in your area. But just to put this in your hat about primary amenorrhea, I would tell you certainly you need to consider referral. Let's talk about something that you'll see way more commonly than primary amenorrhea, and that's dysmenorrhea, and certainly you know what that is. It's painful cramping that's associated with menstruation, and we think it occurs because of excessive uterine muscle contraction. Some people think that it produces uterine ischemia because of the contraction, and that may be what produces pain. You'll see this very commonly in two groups of people. You'll see it very commonly in adolescents, and then you see it more commonly in women in their third or fourth, even fifth decade. So how will you determine what the etiology is? Listen, when a patient comes in with dysmenorrhea, your brain ought to flip to the dysmenorrhea algorithm. And what your brain ought to ask you is this primary dysmenorrhea or is it secondary? And remember yesterday we talked about picking up the clues? You have to get a good history from the patient. This is what clues you might collect if she had primary dysmenorrhea. Look, it means that there's no pelvic pathology. You can pretty much bet she's got loads of prostaglandins floating around, but these are the clues that you'll collect. Typically, these symptoms start in adolescence. Typically, the pain or symptoms that they have start a day or two before the onset of menses, and by 2 to 3 days into menses, the symptoms have resolved. It's always comical to me how many adolescents I see who come in with this, who think they have a GI bug. Look at the symptoms and see why they think that. They come in and they'll tell me, Amelie, I'm having some nausea. Did you vomit? No, but I feel so nauseated. And I'm having diarrhea. I'm tired. I have a headache and I got this crampy lower abdominal pain. If you're an adolescent, it's probably reasonable to think you have a GI bug. So I usually ask them, you ever had this before? About a month ago. And so listen, adolescents are a special breed. You got to help walk them through, really, you got to help walk them through the healthcare system, because this is usually one of their initial interactions and they need help, just the bottom line. So this is what they look like. And the other clue that you will collect from these people is that when they take NSAIDs, they typically feel better. The good news about primary dysmenorrhea is that it improves as people get older, as they grow out of adolescence, and typically as they have children. All right. So if these are the clues that you collected, it's very reasonable to assume that they've got primary dysmenorrhea. You should think secondary dysmenorrhea if these are the clues that you collect. Listen, it usually starts after age 25. In fact, it is more common in the 30s and 40s, meaning the 4th and 5th decades. Very often it's associated with abnormal uterine bleeding. Very often, and this is one of my clues, these patients will report non-midline pain, which is not typical, right? So non-midline pelvic pain, these are not the people who come in and think they have a GI bug, right? So they don't have nausea or diarrhea. Typically, these people's symptoms will worsen over time instead of getting better. So do you see what I mean by collecting the clues? That would help you realize that this looks like secondary dysmenorrhea. So what will you do? You got to get a good history, which means collect the clues, and then you need to do a good physical exam. You do a good head to toe, but we're paying attention and want to make sure that you get a good pelvic exam. You want to make sure that as you do an exam, everything seems normal. She doesn't have trick. You don't feel a big fibroid. There's not anything that makes you think that this is attributable to secondary dysmenorrhea. Sometimes when you find an abnormality, you get a pelvic ultrasound to see what this thing is that you're feeling. But the bottom line is, if the patient has what looks like primary dysmenorrhea, you're obviously going to begin those interventions. If the patient has what looks like secondary dysmenorrhea, then what you'll do is address that, and sometimes that means a referral to somebody else. So for the purposes of our discussion today, let's look at a patient who has primary dysmenorrhea. We want to couple our interventions, meaning let's start with something non-form and add that to maybe a drug or 2 drugs that we're going to give. So listen, exercise is good for everybody, but especially people who have this. It always improves their symptoms, or it certainly has the potential to. And there's something else that will help them, and is the application of heat. So once a month, I want you to make a round in an aisle in a pharmacy. Pick an aisle and go look and see what's out there, because your patients are going to be buying all of these things. Several years ago, a product was produced that looks kind of like a panty liner. Once you open it up, it begins to emit heat. It's adhesive. You can put it on the lower abdomen, and to be honest with you, it gets loads of adolescents back to school, either alone or in combination with medications. What medications? Well, the one that's most commonly used because it's so readily available and generally very well tolerated is an NSAID. You can get them over the counter, obviously. I want you to look at the response rate with NSAIDs and dysmenorrhea. It's 80 to 86%. That's terrific. If you had an 80 to 86% chance of winning the lottery tonight, would you come back this afternoon? Because I'm pretty much thinking you wouldn't. And I know you wouldn't. So anyway, think about that. When primary dysmenorrhea is the diagnosis and NSAIDs do not help, it is certainly reasonable to try one of the hormonal contraceptives. To be honest with you, that ought to knock out symptoms. If it doesn't, you need to rethink your diagnosis, right? Because it might be what? Secondary dysmenorrhea, and it might be something that you missed. Everybody good with me on dysmenorrhea? Let's switch gears and talk about something called PCOS, polycystic ovarian syndrome. This is not a problem with the ovaries. When a woman has PCOS, she's got a head-to-toe problem, and a sets of them. And so it's an extremely common endocrinopathy. I was surprised to learn that up to 8% of females are affected by it. And as I thought about it, it made me not so surprised anymore because I see so much of this in my practice. So listen, at what age is PCOS most likely to present? When do we usually get an idea that she might have this? During adolescence, right? So in teenage years. So look at where the symptoms fall. When you collect clues from your patient who might have PCOS, the clues really fall into two different areas. We have cutaneous clues, things on the skin that we look for. Look, acne, especially outside the time age where we might have expected it. Like a 26-year-old with acne. A 16-year-old, I would expect to have acne. They often do. 26-year-old, maybe not. Probably not. What about hirsutism? Very common. And look at this. Acanthosis nigricans. When did we see that again? Insulin insensitivity. Hold on to that thought because I'm coming back to it. So one place where we look for clues is on the skin. Another place that we look for clues with PCOS are related to anovulation. For example, one of your earliest clues will be a woman who tells you that she doesn't have menses regularly. She doesn't have it monthly. That's going to be one of your big clues. Another clue that you might not see is hyperinsulinemia. So when you say, Amelie, what's so bad about hyperinsulinemia? I will tell you that elevated levels of insulin accelerate atherogenesis. Listen to it again. Increased insulin levels in the bloodstream increase buildup of plaque on the walls of the blood vessels. That's why hyperinsulinemia is such a problem. Do you still believe that this is a problem with the ovaries? Because it's not. It's a head-to-toe problem. And then finally, the last clue that we pick up, especially prevalent in adolescents, is mood disorders. And I have people who tell me, Amelie, you must be kidding. Every adolescent I know has a mood disorder. Well, not really, but we see loads of depression and anxiety and some OCD in higher rates in patients with PCOS than in a matched group that doesn't have the PCOS. So that's what we look for. Now, take a look at what ought to be in your differential. If somebody tells you they hadn't had menses in 3 months, oh, but I don't have a period every month, got to get a pregnancy test. And I'll tell you that because if you only ovulate 4 times a year, you can get pregnant 4 times a year. And I wish I had time to tell you a story about an OBGYN who worked somebody up for this when the patient was pregnant. So you need to make sure that you check a pregnancy test because that's the very first thing that you've got to rule out. And so, after you collect the clues, what diagnostic tests might you get? Well, I'll tell you that the most sensitive measure of elevated androgen levels is the testosterone level. It tends to be elevated. Certainly consider a pregnancy test for the obvious reason. You know what else you need to get in this lady? You need to get lipids. I want you to look at the abnormality that you might find. Look, decreased HDLs, elevated triglycerides. What was that again? What did that indicate? Insulin insensitivity. Oh. Are you beginning to see this disease unfold or this syndrome unfold? An oral glucose tolerance test, you remember we said way more sensitive in our patients? It is more sensitive actually than an A1C or a fasting glucose. ACOG has now shifted and recommends an oral glucose tolerance test to identify diabetes in this group of patients. And then finally, if you still are not convinced that this is what your patient has, you can get an ultrasound of the ovaries. And typically what the radiologist might tell you they find, or you'll observe when you do it, is something called a string of pearls. Remember that? So again, this will work it up. You certainly don't need to do all of those. How do you manage her? Well, you know what it depends on? It depends on whether or not she desires pregnancy. If she does not desire pregnancy, ACOG, the American College of Obstetricians and Gynecologists, recommends that you put this patient on an estrogen-progesterone contraceptive, and what that will do is add regularity to menses, but it protects the endometrium. That's the advantage of doing that. If she desires pregnancy, I'll tell you right now, I'm sending her to see somebody else who knows a whole lot more about this than I do. The drugs that are given to produce or promote ovulation are drugs that I am scared to even let come out of my mouth. One of those drugs is a drug like Clomid. What do you know about Clomid? Clomid makes humans have litters. And I'm like not even into that. So I will never write a prescription for Clomid or one of the other drugs. If you work in fertility, you'll say, Emily, I do that all the time. Oh, I do it all day. Well, good. I'll send you my patients. All right. So listen, to wrap it up about PCOS, and I don't want to make a joke about it because it's a serious deal. These women need to be watched throughout the lifespan. Look at what they're at increased risk of. Endometrial, breast, and ovarian cancer. We see loads of issues with elevated lipids and elevated insulin and diabetes. And then finally, all of this typically ends up with cardiovascular disease. This is not a quality of life problem. It's a quantity of life problem. And then finally, I think one of the most frustrating issues is infertility. Because you know as well as I do, you can dump $20,000 or $30,000 in a fertility clinic and not come out pregnant. You got it? So be very gentle and sensitive to this group of women, and to be honest, you're going to see lots of them. So good attention to healthy lifestyle throughout the lifespan. What about cervical cancer? It's extraordinarily common, not just in the United States, but honestly, worldwide, and almost always it is secondary to infection with HPV. Certain forms of HPV are more oncogenic than others, but here's how you need to think about it. HPV is a sexually transmitted infection. Both men and women get it. When women become infected with HPV, our risk of cervical cancer rises very much, especially if one of these types of HPV is a causative agent. We are very lucky in the United States that we have 2 vaccinations or immunizations that will protect or prevent HPV, the most oncogenic forms. It's routinely in the immunization schedule 11 to 12 years of age, and it's recommended by not only ACOG, but ACIP. ACIP is the immunization arm of CDC, and I would tell you that generally 11 to 12 years is when people get this, both girls and boys. Let's talk about recommendations for cervical screening. And I think you just need to put these facts in your brain. The first fact that I think you should put in your brain is the age of initial screening. The age of initial screening is age 21. There are some exceptions, but having multiple sexual partners is not one of them. An exception to the age 21 might be someone who's less than 21 years of age and HIV infected. Someone who's less than age 21 and sexually active who's got lupus. So we're looking at people who are less than age 21, who are sexually active, who have something that compromises their immune system. You follow me? Those are the people who represent an exception to the age of the initial screening at age 21. This is why we don't screen at less than age 21 for the general population anymore. ACOG has loads of data that says that it just isn't supported by the evidence, and here is the evidence. The first thing you should know is that HPV clears spontaneously in adolescents and young adults. It goes away by itself. And the incidence of cervical cancer in young adults or adolescents is 0.15 per 100,000 people. You know what that is? 1.5 per million people. 1 in a million. How unlucky are you feeling is the question. So my point is, ACOG looked at all of the data, and that's why it came out with a recommendation. So if we screen you at age 16 for HPV and we find it, we're going to treat it. And when we treat it, it has implications for you with fertility down the road, and that's exactly why we don't do it. All right? So it's evidence-based recommendations. Another fact to put in your brain is, when do we stop doing PAPs? Well, ACOG recommends age 65 with a little asterisk, provided the woman has had adequate screening. And they give you a definition of adequate screening, and certainly is right there. I really think that we are going to see a change in the recommendations for older women. And here's why. We know that the highest incidence of cervical cancer and mortality is in older women who have not been screened. That's it. I mean, there's just been a big study that was released. So I honestly anticipate it's going to take 2 or 3 years, but I think you'll see a change in the recommendation for older women. But generally, we stop at age 65 if they've been appropriately screened. The next fact to put in your brain is how often we screen. What's the frequency and how do we do it? Well, starting at age 21, we screen every 3 years with PAP only. Just put the fact in your brain. Starting at age 30, we screen every 5 years with a PAP and a reflex HPV, or an HPV, I should say. All right? So that's generally what we do. And certainly there are some exceptions, but these are the recommendations and the consensus of the 3 learned authorities with regard to women's cervixes. Look at who they are. American Cancer, ACOG, and the colposcopy people. This is a recommendation, consensus recommendations. They're heavily evidence-based, and honestly, I would ask you to follow these in your clinical practice. What do you do with a woman who's had a hysterectomy? Does she still need a PAP or not? There's a question you have to ask. And the question is, why did she have a hysterectomy? If the hysterectomy was for benign reasons, meaning maybe she had a big fibroid, it caused heavy bleeding, and that's why she had a hysterectomy, ACOG's recommendation is to discontinue PAPs. It doesn't mean discontinue a pelvic exam to look for other pathology, but it means discontinue PAPs. If she had a hysterectomy and it was not benign reasons, in other words, maybe there were dysplastic cells, the recommendation is divisive. Listen, American Cancer says you should screen her until you get 3 negative PAPs in a row. And if you get 3 negatives, you can stop. ACOG says, oh no, we want to do it for 20 years. So it's somewhere between 3 and 20. I don't know where it is. What about special populations? People who don't fit into these recommendations of the general population? Certainly these are people, and we've mentioned them already. Look at my slide. What's this arrow pointing to? It's a cervix, but the arrow is pointing to something that goes by several names. Some people call it the T-zone. Some people call it the transformation zone. Some people call it the zone of transition. I don't care what you call it. The significance of that is when you do a PAP, you must collect cells from that area. And here's why. That is the squamo-columnar junction. Look, it's the place where squamous cells and columnar cells come together. And the reason that is so important is because if there's going to be dysplasia, that is the place where you find it. So the significance of the T-zone is that it is a squamo-columnar junction, and if they're going to be dysplastic cells, that is your best place to find them. How do you collect the cells? Well, we have a number of instruments that you could use. You could use a spatula to collect cells from the inside of the ectocervix. You could use a brush to collect cells from the endocervix. You could use a broom that collects them both at the same time. After you collect your cells, now you have a decision to make. Where are you going to put them? We used to put those cells on a slide. We'd fix it, send 2 of them over to histo, and histo would look at them, and as long as everything was okay, the 2 slides were good. But if histo saw something that was amiss, they might say, listen, I want you to bring the patient back, because you know what? We use those 2 slides, and they have stain on them and we want to do something else, and we don't have another specimen. So an option for you today is to take the cells that you collect and disperse them in a liquid medium. The advantage of the liquid medium is not that we have higher rates of cervical cancer identification. The advantage of the liquid medium is that when histo gets it, they can make as many slides as they want. They can put as many stains on it as they want. They can make a slide and send it over to the world's foremost authority in whatever they see. So that is the advantage. The disadvantage is that the liquid mediums tend to be more expensive than the traditional slides. And certainly that is the case in the place where I live and visit many venues around the United States. After you send your slides off, you will wait and make sure that your office has a reliable way to track those results coming back in. What you would like to see on the PAP report is this: negative intraepithelial lesion or malignancy. That's always what we want to see. It's not what we always see. Very often you'll get something called an Ask Us PAP, and what you will do with that will depend on who your patient is and how old they are. People who absolutely will need colposcopy when you get PAP results back are people who have these results: an LSIL, an HSIL, or atypical glandular cells. If colposcopy is not within your realm of your skill set, you'll have to send them over to somebody who can do that, because this is what they need at this point. You got it? So have some resources in your area for what you will do, because I tell you, if you do PAPs, you get abnormal ones back, and then you'll have to figure out what you'll do with them. Is everybody good? Let's talk about vulvovaginitis, which is a miserable condition for people who had it. There are 3 common reasons that people or women present with vulvovaginitis. Probably the most common is BV. We referenced that yesterday afternoon. Another common one is secondary to infection with Candida albicans, and sometimes vulvovaginitis is secondary to what STD? Trick, absolutely. Women tend to be very poor at self-diagnosing this. They tend to be very poor, which is why you got to collect a specimen and see what's going on. So here's your patient. A patient has been diagnosed with vulvovaginal candidiasis. Which choices listed below are predisposing factors? What increases her risk of it? Well, number 1 sure does. Number 2 and 3 certainly do. What about number 4? Did you read the word? Immunocompetence. It's not immunocompromised. So let me ask you, did your fatigue factor kick in on it? Yes, okay. You see what happens when your brain gets tired? So circle number 1, 2, and 3. These certainly will predispose you to it, but not number 4. Everybody got it? All right, let's keep going. I made a chart for you because I think it will help put things in perspective. When we look at the 3 most common reasons women have vulvovaginitis, it's pretty easy to compare them by using the patient's symptoms, by using pH, a great tool, by using a whiff test. You're laughing about that, huh? All right, you remember the lady from yesterday. And then to use a KOH. Often we see that with candidiasis. So anyway, this is just a good way to help put it in perspective for you. So feel free to use my chart. What about this? When you see vulvovaginitis in a woman, especially secondary to a candidal infection, I want you to look at them and think that maybe they might have another disease in disguise. Like maybe this is a woman with an undiagnosed diabetes. Maybe she's immunocompromised, or heck, maybe she's got HIV. So put on your thinking cap when women walk in with candidiasis. Look at these slides. The one on the top left is one where I see squamous cells and I see hyphae. And when I see hyphae, it makes me think of a woman who's probably got a candidal infection. Look at the one underneath it. This one is obviously stained. It is a stained slide. And I see big epithelial cells. I see a little pile of bacteria. But what has absorbed a lot of the stain is hyphae. It's made it look very thick compared to the hyphae that you see in the top slide. The other thing that I see are these very dark, big purple circles. What is that? Those tend to be yeast, right, or big buds. They absorb stain very, very readily. And when I look at a slide like this, it makes me think this patient's got a yeast infection. Look at the one on the top right. Because this slide's been KOH'd, and the advantage of putting KOH on a slide is that it destroys the cellular elements. It makes what you want to see more visible. So take a look. These are like all buds, right? The way that yeast reproduce is by a process called budding. What does that mean? A yeast wakes up one morning and says, I think I want to make a baby yeast today. It pinches off a piece of itself, and the piece it pinches off will make a new baby yeast. How long does that take? 2 to 3 minutes. So I'll save you the math. But 1 beget 2, 2 beget 4. 4 beget 8. So look, here's a yeast that's in the process of budding. See, it kind of looks like a turtle. Right here is what we see. And what looks like the head of the turtle is going to be a new mama yeast who might decide to make more yeast very quickly. Look at this one having twins. When they have twins, you better look out, right? So they can reproduce very quickly. And the point of making you realize that is that a woman can go from being not so symptomatic to very symptomatic in less than 24 hours. You get it? So this can happen very, very quickly. How do we get them better? We have 2 options. If she's been reading Cosmo, she's going to say, Amelie, I want diflucan or diflucan. To be honest with you, it's an easy way to go, and it might be the least expensive way to go. But you need to know about fluconazole, and here's what you need to know. When you swallow this pill, it remains therapeutic in vaginal secretions for, look, 72 hours. Excuse me, you know what that means? That means that for 72 hours, every time this drug sees a new baby yeast, bang, 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 it's just killing new yeast for 3 days. Do you really think you need more than one of them? You shouldn't. If you need more than one diflucan, bells ought to go off for you. You know what it means? She's either got one rip-roaring infection or she's got something else going on. And if she's got a rip-roaring infection, I want to know why. Probably because she has something going on. So I just want you to use your good judgment about people who call and need refills, all right? The other option instead of an oral agent is a topical agent. You can get them over the counter, and to be honest with you, the advantage of these is honestly that they're very readily available. But these drugs, you can put exactly where the infection is, which is what ought to help you here. Look at my question I just gave you the answer to. Which treatment for vulvovaginal candidiasis relieves symptoms most rapidly? Well, you will always relieve symptoms more rapidly if you put the drug exactly where it needs to work, rather than swallowing it, let it swim around your bloodstream and find its way to the vaginal tissue. So what is the best answer? Look at number 1, a topical azole antifungal. So when people need quick relief, consider a topical agent and or an oral agent. Everybody got it? What about atrophic vaginitis? Very common. We see this in older women, postmenopausal women, and very often they have a discharge. And so what are your clues? Because this is how these patients come in. They sometimes come in and tell you it burns when I urinate. And so you think maybe a UTI, but often when the urine is negative, this is what's got to be in your differential. They'll come in with urinary tract symptoms. How come? They come in with urinary tract symptoms because during embryology, urinary and genital tissue are derived from the same parent cells. So when one tissue dries out, the other does as well. So it's not unusual or uncommon for these women to come in with urinary tract symptoms. Typically, they respond to topical estrogen. So in your older adults who come in with these symptoms, I want you to consider atrophic vaginitis. What about postmenopausal bleeding? Pretty darn common. A load of GYN visits are secondary to this one. And so here's what happens. You need to realize that with postmenopausal bleeding, it is way more likely to see it very soon after menopause than later after menopause. Later after menopause ought to raise red flags for you. So early in menopause, it can happen because of hyperplasia. It can happen because of thinning of tissue. It can happen because of a fibroid. But look at my question. Here's your patient. She is a 60-year-old female who has begun to have a small amount of blood escaping from the vagina. What's the most common cause of malignancy when one is found? What are we worried about her having? Endometrial, right? Endometrial cancer. And so let's talk a little bit about postmenopausal bleeding. The most common reasons that people have bleeding postmenopausally is secondary to atrophy. It's a common thinning of the vaginal tissue. Sometimes it occurs secondary to polyps, but the one we look for, because it's pretty darn common, 1 in 10 people has endometrial cancer. And so I would encourage you to look for these or consider which ones. But if you can't identify why the bleeding is occurring, you got to get this patient referred. And so how will you work her up? The first thing you'll need to do is a pap smear and exam. See if everything seems like it's okay or if anything is amiss. Depending on what you find, You may do a transvaginal ultrasound, especially if you palpate something that feels like it's it's abnormal. And then depending on your skill set, you may do an endometrial biopsy. It just depends on what you find, and it depends on your skill set. Honestly, a lot of these patients are going to be referred out of primary care because they need an intervention that most of us are not equipped to do. What about those two diseases that we put in women's health, but we see in men as well? One of those is osteoporosis. And women get all the attention with this, but men have osteoporosis as well. So who's at risk? Well, I'll tell you that if you watch the Boniva commercial, they tell you exactly who's at increased risk for osteoporosis. Who is it? It is a skinny little white woman who smokes and drinks. That's a classic picture of an osteoporotic patient. But there's two populations where we see it very much. We see it in Caucasians and we see it in Asians. So in the Boniva commercial, when he had that round table in that cafe with those 4 women sitting around the table, one of them is Caucasian, another one is Asian. And so what they're trying to tell you or have a woman identify is herself in one of those patients. Right? So anyway, consider this. These are your most important risk factors. Both exams, I think, are going to ask you about a T-score because that's how the DEXA scan is reported. The DEXA scan is what we use for screening and diagnosis of osteoporosis in both men and women. So what is the deal with a T-score? Do you remember about the number line? What grade were you in when you learned about the number line? Because I think I was 2nd grade. What were you? Don't tell me pre-K. How old were you? You don't remember. Look, here's a number line from your perspective. This is 0, all right? So here's 0. Everything to the right of 0 is where you want to be. That means you got good, healthy, solid bones. Once you cross over 0 into the negative part of your number line, you begin to become at risk. Here is -1. Here is -2. Here is -3. The farther you get away from 0, the smaller your numbers get. So -3 is smaller than -2. You with me? All right, now, if you have osteopenia, which is what this question asks, they're asking where would your T-score be? It's going to be between, look, -1 and -2.5. If the question had asked osteoporosis, you would have answered -2.5 or less, meaning farther to the left. You got it? Everybody follow me. So the answer to the question as it is written for osteopenia is number 2. Next to number 3, I want you to write osteoporosis. I don't know which one you'll see, but you need to know them both. Everybody with me? The DEXA scan is what we use for both screening and diagnosis. And once you identify it, you got to get your interventions going. Certainly we want to make sure she or he consumes adequate amounts of calcium and vitamin D. Certainly that they engage in weight-bearing exercise. And then we arrive at a point where we need to consider whether or not a bisphosphonate would be in order for this patient. If a medication is given to prevent bone loss, typically the bisphosphonates are considered first line because they inhibit bone resorption, they increase bone mass, so they have the potential to. And finally, you should be familiar with the names of some of these, and they are the drunates, right? So if you're keeping a suffix list, you might put that on your list. Those are drugs like Fosamax, Actonel, Boniva, all right? What about a breast mass? We see this in both men and in women, and it's just that we see them way more commonly in women. The vast majority of breast masses are completely benign, unless you are the patient, right? And so let's take a look at how you would assess a breast mass. In the United States, we have several different ways to do it. Maybe the most common way to assess a mass is with mammography, but there are a couple of limitations. One of them is age. Because younger breasts tend to be very dense, mammography doesn't offer as good information in a breast that is less than 30 years of age. So in someone less than age 30 with a breast complaint that we need to evaluate, an ultrasound may be a way better way to evaluate the mass. It is also a way better way to evaluate a mass in a pregnant woman because, as you know, mammography imparts what? Radiation. An ultrasound has no radiation, so consider that always in your pregnant patients. There is another modality that we use for routine screening in women who've already been diagnosed and treated for breast cancer. We get mammography. What's the other one? MRI, right? It's a standard of care according to American Cancer for patients who've been diagnosed and treated for breast cancer. And so, why on earth would you get an ultrasound besides elimination of radiation and in someone who's less than age 30? When you evaluate a breast mass, the advantage of an ultrasound is that it differentiates a fluid-filled from a solid-filled mass. You got it? That's why you get ultrasound. So ultrasound is typically used in combination with mammogram to assess a focal lesion that you have found. Which brings us to breast cancer. So take a look. This is way more common in older women. Let me show you the numbers. By age 30, a woman's risk of developing breast cancer is 1 in 2,200, and that's not very great. Just 10 years later, look what happened to her risk. It goes up to 1 in 235. By age 50, look at her risk. 1 in 54. The lifetime risk of a woman with breast cancer is 1 in 8. So when you look around this room, that means a lot of people. And I'll bet you there's somebody in here who's already had breast cancer. So it's extremely common, which is why screening and assessment of risk factors becomes very, very important. I want you to look at the risk factors. I think you're familiar with them. But look at screening because it's a controversial point. American Cancer, American College of Radiology, ACOG, AMA, all recommend annual screening of mammograms for women starting at age 40. Annually starting at age 40. Other groups, the United States Preventive Services Task Force being one of them, recommend starting at age 50. And the United States Preventive Services Task Force goes even one step farther and says, do it every other year, not annually. So I want you to realize there's a lot of discussion and difference in screening recommendations. I don't think you can get a question on the exam because it's just too controversial at this point. But anyway, screening, use your good clinical judgment as to how often to screen this patient. Whew. Take a big deep breath. You ready? Which choices below are causes of secondary dysmenorrhea? Okay, wait. Secondary dysmenorrhea. All right, I got it. What about number 1, endometriosis? Yes, that's what you'll look for when you do a pelvic exam. You'll look for the presence of fibroids. Yes. You look for adhesions in patients in whom that's likely. And then finally, does PID increase your risk of dysmenorrhea? Absolutely, right? So anyway, all of them do, and when you do an exam, these are some of the things that you look for. Here's your next patient. A 17-year-old female is HIV positive. Oh, that's not good. What's the recommendation for cervical screening for her? You know who she represents? An exception to the rule of doing a PAP at age 21. So listen, she's HIV positive. She needs to be screened now. If she is negative, she gets screened again in 6 months. Look at number 2. And then she is someone who gets screened annually. You got it? So circle number 2 and add then annually. You got it? All right. There is some updated information for you on contraception. I would invite you to take a look at it. Typically, we just don't get many questions on the exam about contraception. I have included the information in the thought of being very thorough for you. But let's talk about men's health. You ready? Look at this man. What do you think he's saying? What do you think he's saying? Oh, my God. You think he's saying, I can't urinate? Because that's what I think he might be saying. Here's what we need to talk about with regard to men. We need to talk about a man's prostate gland, which means we got to talk about BPH. It's so darn common. We must talk about prostatitis because it's darn common as well. And we've got to talk about the number one cancer that we see in men, prostate cancer. All right? Then we'll talk about epididymitis. On your exam, who is the classic epididymitis patient? You know, a farmer or a lifeguard is a skin cancer guy. Who's your epididymitis guy? A truck driver, somebody who sits a long time. We'll talk about it when we get to it. In the realm of men's health, what's your emergency diagnosis? Testicular torsion, right? Got to be. And the cancer that we see in younger men is testicular cancer. I've got to make sure you know about that. Give me 25 minutes and I'll have you out. You ready? Let's talk about BPH. You know, they say that if men live to be old enough, every single one of them is going to develop BPH. It's a non-cancerous enlargement of the prostate gland, and to me, if you see it, you've got it. So take a look. Here is a man's prostate gland. It is embedded in the lower pelvis, in fat and in bone. If you want to examine a man's prostate gland, you have to do a rectal exam. It's the best way to examine it. I want you to realize that even if you do an excellent rectal exam, you are never able to palpate the entire gland. The second thing I want you to consider when you look at this picture is this. I want you to consider that this man is developing BPH. And I want you to consider that his prostate gland right here is beginning to enlarge in an upward fashion. And I want you to imagine that as it grows in an upward fashion, it begins to pinch off the neck of the bladder. What symptom do you think this man is going to have? He's going to have urinary retention. You know what else he's going to have? He's going to have difficulty starting his urinary stream. So he's going to have to push to get urine out. Suppose that instead of increasing in size in an upward fashion, pretend that the prostate gland increases in size and it begins to squeeze and narrow the diameter of the urethra. If that happens, do you know the symptoms this man is going to have? He's going to have a weakened urinary stream. You know what else? He's going to have to push to get urine out. And when he stops pushing, urine is going to get caught right here. So that when he walks, he's going to have dribbling. Women, do you agree that that's completely unacceptable? Unacceptable. So I think if you look at this picture and you imagine what happens with the prostate gland, it makes it easier to see why people have the symptoms that they have. So first question for you. At what age is the finding of BPH most likely? What I'll tell you, the most likely age is age 80, right? 80. Yeah, absolutely. Let me show you the chart and see how you'll know. Listen, it becomes most likely at the oldest age. It's 80% of people at age 80 have it. At age 60, we're looking at people who are less than 50% of the population. I wouldn't expect you to know that, but your take-home point is the older a man gets, the more likely it is that he'll develop BPH. Now, I want you to pretend that this is Mrs. Thibodeau. And Mr. Thibodeau has BPH. Here's what happens. As Mr. Thibodeau develops BPH, one of his earliest symptoms is a decrease in his urinary stream, and he doesn't tell anybody. He goes to the bathroom, he has to push, but nobody knows but him. As his symptoms worsen, he is going to develop nocturia, which means that he's getting up in the middle of the night to go to the bathroom. And every time he gets up, he wakes her up. So finally, after a couple of weeks, she looks at him and says, "Honey, you got a problem. It is not normal to wake up in the middle of the night to go to the bathroom. You need to go see about your problem." What does Mr. Thibodeau say? "I'll call this week." Does he call? No. They decide to go to the mall to go shopping. When he gets to the mall, what does he tell his wife? "I gotta go." Why? Because he's having frequency and urgency. This man will know every bathroom between home and his most likely places. Grocery store, Walmart, Home Depot. He doesn't know where the bathrooms are. So he's at the mall and she's wasting valuable shopping time waiting for him to come out of the bathroom. And when he comes out of the bathroom, she can't believe what she's seeing. What does she say? What does she see? Wet. What does she tell him? Honey, we are going to see about your problem this week. And that's when they arrive in your office. So listen, you always know something is up when they both arrive in your office and he's the patient. You know she wants to make sure he tells you the whole story. So that's a situation right now. They are both sitting in your office. You can ask him about these symptoms. What's he going to say? Yeah, I got them all. You're going to get him to urinate in a cup. It is not unusual to find hematuria, microscopic hematuria. You're going to examine him, and the way you'll document the finding in BPH is a firm, smooth, symmetrically enlarged prostate gland. All right? Before they leave, you're going to say, Miss Thibodeau, I want you to make sure that y'all go to the lab and get a PSA. And what's he going to say? I'm not fasting today. I can't go today. Right? Isn't that what he's going to say? You don't need to be fasting to have a PSA. Mr. Thibodeau, you're going today. All right? So listen, there's some things that can make the PSA go up, but digital rectal exam is not one of them. So send him today to go get the test. I want you to note there's some things that can drive the PSA up or down, but to be honest with you, your take-home point is that we no longer delay a PSA because the DRE has been done. Look at my question for you. What are the major causes of an elevated serum PSA? Well, BPH can drive it up. Prostate cancer certainly can, and so can an acute infection in the prostate gland, which is why we don't measure a PSA in a patient who's had or has an acute prostatitis. Which one is not? Number 4 is not. Don't circle that one. Urinary tract infection won't drive up a PSA, but these other 3 certainly will. There's a term that you should be familiar with regard to prostates, and it is PSA velocity. It's the rate of PSA change over time, and we always worry about a PSA that escalates over time rather than one that remains elevated over 3 or 4 or 5 years. You should be way more worried about a PSA that goes from 1 to 4 than one that is 3 year after year after year. It is the PSA velocity that might prove helpful for us in the future at predicting who is at increased risk for an aggressive prostate cancer. Quick question. Is there a range that you look at? I would tell you that in primary care, when we look at a PSA velocity, we compare 1 year to another year to another year. So that when you see a PSA that doubles, even though it may be really close to normal range, that always makes me worry a lot. And it is because of the possible predictability with aggressive prostate cancers and PSA velocity. All right? So how do we manage this man who's gone to the bathroom, got to go to the mall? What are we going to do with this man? Well, you know what? If we could put him on an alpha blocker, we would help his symptoms because your urinary tract, men and women, is loaded with alpha receptors. If we block up all those receptor sites, you know what happens? Urine flows, which is why a marketing coup was a drug name called Flomax, maximum flow of urine, all right? So I think that's a cool name, and that's how we got it. So listen. There are several different types of alpha blockers. Some are non-selective. We used to use those a long time ago for management of blood pressure. We don't use them so much anymore. We now have a generic urinary tract specific alpha blocker called Flomax, and you'll see that used all the time. So BPH, think Flomax, certainly will help this man's symptoms. If it doesn't, you need to get him out to urology. So that's BPH. You'll see a load of it. There's something else that you will see, and it is called acute bacterial prostatitis. It means that the prostate gland has been invaded by either bacteria from the urinary tract or maybe a sexually transmitted infection. Men who have this will tell you they feel like they've been in a bar fight. They feel like they've been in a bar fight. They ache, they run fever, they have pain in the pelvic area. Sometimes they have pain in the testicles, and they're coming in. They're coming in. Your job is to figure out what in the world's causing it. So if you think that it is an STI, you need to make sure that you do your screens. You certainly need to get a urine at the same time because it could have been translocation of bacteria from the urinary tract into the prostate gland that's caused it. Regardless of the etiology, you're going to find a man who comes in very acutely. They come in with fever and chills and malaise. When you examine his prostate gland, this is how you will document it. It's enlarged, boggy, and tender. Do you remember how prostates are supposed to feel? A normal prostate gland should feel like the tip of your nose. Firm, symmetrical, smooth. A boggy prostate gland feels like your cheek if you puff it out a little bit. Look. My clue that lets me know or even think about this is the question I asked this man is, when you had bowel movement this morning, was it painful? And if they tell me yes, this is what I think of, and here's why. If you look at the position of the prostate gland, if it's enlarged and boggy and tender, and stool comes down the rectum, the diameter of the rectum increases, and it pushes on the tender prostate gland. That produces pain with the bowel movement, and for me, excuse me, that's a very good clue that the man may have bacterial prostatitis. It's very important when you do a rectal exam that you are very, very gentle simply because there's bacteria in there and it hurts. So take a look at my question. Why should gentle prostate gland or exam be performed in the setting of likely bacterial prostatitis? One is because it's painful, so circle number one, it's uncomfortable. But secondly, it can increase the risk of bacteremia. So circle number 1 and 2, and that's your best answer. So what will you do for this patient who's got acute bacterial prostatitis? You got to get an antibiotic in them. If it is secondary to a urinary tract pathogen, I suspect you'll be using a drug like Cipro. But here's your take-home point. Prostate glands do not absorb antibiotics very readily. You know what that means for you as a prescriber? You got to prescribe an antibiotic for prostatitis week after week after week after week. 4 to 6 weeks to treat a bacterial prostatitis. Please be kind to this man and recommend a stool softener because it will certainly make his bowel movements less painful. And to be honest with you, if you can't get this man better in about 2 to 5 or 6 days, depending on how acute he is, you need to get him into urology. Everybody got it? So that's acute bacterial prostatitis. Sometimes men have prostatitis and it is considered chronic. The prostate gland is old and angry. That's what it is. It's old and angry prostate gland. And these are patients who come in and they tell you, I think I have a UTI. I feel like I have a bladder infection because those are the types of symptoms that they've got. When you do a prostate gland, it typically is normal, although it may feel like an enlarged prostate gland. The treatment is often antibiotics. We often think that bugs in there, and to be honest with you, you can't rule out that that's not the case. So consider that in you men who have recurrent urinary tract symptoms. Yes? PSA and chronic prostatitis almost always is elevated. So in the presence of some prostate issue, we tend not to get a PSA because then you got to follow up on what will likely be an abnormal one. All right, good question. What about prostate cancer? Number 1 cancer in men, and I'm pretty sure that you're going to see a question on the exam about it. Listen, who's at risk? This is the one that we see in older males, especially African Americans and Jamaican Americans. Those 2 groups of men have the highest rates of prostate cancer in the world. And look at my question for you. Most men who are diagnosed with prostate cancer present with what? I'll give you a clue. They're asymptomatic, but they present with an abnormal PSA, which is why it is important to use a PSA as a screening tool in specific populations of men. They do present asymptomatically, but one clue that ought to prompt you to do a good prostate exam in this man is someone who presents with new onset ED. New onset AED may be your clue that this man has prostate cancer, so certainly you'll check that. We talked about what a prostate gland feels like if there's a tumor. It feels nodular and hard, kind of like the hard part of your head. And then you do a digital rectal exam, and we often get a PSA, and typically we do. Here are the numbers. In patients who have prostate cancer, we typically expect the PSA to be elevated, but it isn't always. In fact, about 50% of the time it isn't elevated, which is the value of doing a prostate exam in these men. When you palpate something that feels abnormal, your job in primary care is going to be to get these men into urology. So take a look at my next question. It starts out with select all that applies, so you know it's going to be a tough one. Screening for prostate cancer is most beneficial in men who? Well, I'll tell you that a new change in when we get PSAs has to do with number one. We don't get PSA in a man whose life expectancy is less than 10 years. Prostate cancer tends to be slow growing. So less than 10-year life expectancy, we stop measuring PSAs. We certainly want to get a PSA in number two, people with a family history. We certainly like to get a PSA in someone who's got an older brother with prostate cancer. You got it? And certainly anybody who desires screening ought to be screened. So which ones would I circle? Number 2, number 3, and number 4, but not number 1. And that's a take-home point for you. Everybody with me? So what about prostate screening? We talked about screening women's cervixes. What about men's prostate glands? Well, PSA is the way we screen usually. It is a good marker, but it's not great. It's certainly far from perfect. PSA velocity is pretty good, but it's not perfect either. We don't have an ideal way to screen men's prostate glands. And so American Cancer recommends this. They recommend that men of average risk, meaning their older brother didn't have prostate cancer, their father didn't have prostate cancer, that we screen them with or without digital rectal exam starting at age 50. If they are at increased risk, American Cancer says screen earlier, and American Cancer is all about screening discussions. They want you to have a conversation with this man. When you screen with a PSA, if the number comes back less than 2.5, American Cancer says screen them every other year. If the number of the PSA that comes back is 2.5 or less than 4, American Cancer recommends annual testing of a PSA. If the number comes back greater than 4, American Cancer says you need to refer for evaluation. You got it? So that's what you do with the numbers based on a PSA. But again, shared discussion. And this is a very, very hot topic right now. I guess the bottom line for you, informed and shared discussion with your patients. What about epididymitis? If you're in this room and you have an epididymis, it is right here. It is that little comma-shaped organ, and it is right here. And what that thing does is it harbors pathogens sometimes. If you got an STI or you've got a urinary tract pathogen, sometimes bugs will translocate and infect the epididymis. But there's another reason why men have epididymitis, and it is because they sit too long. So on your exam or in the clinical exam room, I want you to look for a man who comes in with symptoms of this, who has a job or an occupation where he sits and sits and sits. A truck driver, an accountant, a computer programmer, those are often the ones that they'll give you on an exam. And so, how do you know this? How would you even guess that this is what this man had? The primary symptom of epididymitis is gradual development of scrotal pain. What is always in your differential with scrotal pain? Testicular torsion, right? So that's always got to be in your differential. And so the epididymis, when you palpate, it tends to be very, very tender. So again, do a very gentle exam. If you're thinking that the epididymitis is secondary to an STI, you're going to have to get your cultures. You know, check for gonorrhea, chlamydia, do your thing, and then get a urinalysis as well and treat whatever you find. If it is non-infectious, then generally the way we treat epididymitis is to make this man drink a glass of 8 ounces of water every hour while he's awake. What does that do? Makes him get up and go to the bathroom. Get up is what we want him to do. So I'm really kind of kidding about 8 ounces of water every hour while he's awake, but we want him to drink and drink so he has to move. The other thing to consider is certainly an NSAID and an analgesic, but honestly, if you've got him on the right treatment, he ought to be better in about 72 hours. If you've got to get him on an antibiotic, the epididymis doesn't absorb antibiotics very readily, neither does a prostate gland. Look, 2 to 4 weeks of an antibiotic therapy if he's got an STI and epididymis. You got it. So it's not a quick done deal. Look at this question. A 26-year-old male has a scrotal mass with mild tenderness. There are vowel sounds in his scrotum. Now, how do you know that? How do you know there are vowel sounds in his scrotum? Don't tell me you did that. Okay, hold on to that thought. I'm coming back to it. Listen, vowel sounds in the scrotum, scrotal mass. What's your likely diagnosis? It's an inguinal hernia, right? Circle number 4. Let's look at the picture. So listen, what's a hernia? It's where a loop of bowel breaks through the muscular wall, typically the abdomen. Look, here's an inguinal hernia. And if you've got a loop of bowel that is broken through the abdominal wall, you can get transmission of bowel sounds into the scrotum. So I have never been able to do this and keep a straight face. But what you got to be able to do is look at your patient and say, Mr. Boudreau, I think you might have a hernia. And an easy way for me to assess that is to listen to your scrotum. If you don't tell him what you're about to do, you're going to wake up on the floor because he will have punched you. So you let him know what you're going to do and ask for his permission. But listen, you know good and well you're not going to put your stethoscope down there. What will you do? You take the diaphragm of your stethoscope and put it in a glove. Tighten the glove over the diaphragm and listen. If you hear bowel sounds, it's very likely a loop of bowel, and that's what he's got. If you don't hear anything, he's going to need a what? An ultrasound, absolutely. All right, so again, there's where we are. Almost there, hang with me. What about testicular torsion? Look at what happens with testicular torsion. The testicle becomes deprived of its blood supply. Really? Yeah, that's exactly what happens. The spermatic cord twists, and any part of you that is deprived of its blood supply, whether it's myocardium or gut or a testicle, will begin to create pain very, very rapidly. And so that's typically how these patients present. It's a sudden onset of testicular pain. And so here's your patient. I have a correction that I want you to make. I'll give it to you in a second. Here is your patient. A patient suspected of having left testicular torsion has a negative cremasteric reflex. I want to know, when the left inner thigh is stroked, what happens? The correction I want you to make in number 1 is to make it a left testicle. And the correction I want you to make in number 2 is to make it a left testicle, not a right. You got it? So the man's got testicular torsion, or suspected. He's got a negative cremasteric reflex. When the left inner thigh is stroked, what happens? If he doesn't have a reflex, the testicle's not going to rise. But you know what? When you stroke the left thigh, the right one doesn't rise as well. So it's a tough question and harder than one I thought. The testicle on the left will not rise, but you know what? The best answer is that neither testicle rises. You got it? This is an ipsilateral finding, not a contralateral finding. So cremasteric reflexes, if everything is working, then when you stroke the inner thigh, the testicle rises on that same side. If it's negative, it will not rise, but the other one doesn't rise either. So your best answer is number 3, neither testicle rises. You got it? All right. Torsion. Tender, high-riding testicle is how that's described. That's exactly what you'll describe in your note. And here's why it's described that way. Because as a spermatic cord twists, the testicle is elevated. You got it? And it becomes extremely tender and painful. Your job is to get them out PDQ. PDQ. Pretty damn quick, right? Get them out. You got about 4 hours to reestablish blood supply, and if you don't, you got big trouble. What about testicular cancer? This is a cancer that we see in young men. Look at the age, 15 to 35 years. It is highly curable, especially when it is caught early. Who's at increased risk for this? Any male infant that was born with cryptorchidism. What's that? An undescended testicle. Even if it has been repaired, the risk of testicular cancer is increased. Is this someone you want to teach about testicular exam? Absolutely. Right? So how would you find this? What would you note? The ones that I have found feel like, you palpate the testicle and you will feel something that feels like either a BB or a small bean. You'll just be able to tell whatever is there doesn't feel like the rest of the testicular tissue. And that ought to be your big clue that you're going to need scrotal ultrasound and always a referral to urology. When they biopsy it, if it's found to be malignant, they will typically have this male, who may be an adolescent, donate sperm right now. It's preserved because we expect to cure them. But once they get treatment, sperm production usually is decreased or absent. So sperm donation ahead of time is typically how this is managed. And honestly, really, really good survival rate. Take a big deep breath. All right. Here's your patient, a 22-year-old male, presents with a complaint of scrotal pain after a minor car accident. This is one of my patients. What must be part of the differential diagnosis? Okay, wait. Scrotal pain after a minor car accident? I'm thinking of torsion, right? That's absolutely it. Scrotal pain, number 2, circle it. Look at this next question. Which factor listed below is not a risk factor for ED, erectile dysfunction? Well, advanced age certainly is. Diabetes or elevated glucose certainly is. And so is hypertension and diabetes. So which one's not a risk factor? Number 3. Hey, wouldn't it be great if number 3 was a risk factor? Of course, I'm the girl who thinks we ought to have an STD day. I really do. We ought to have a day, one designated day a year where everybody in the world is treated for STDs. Really, we would knock them out.